I will get started then. Good morning, everyone. Happy May ACC conference. I'm excited to introduce our panel today. We're going to be discussing injection drug use and many aspects of injection drug use and our approaches to deliver care to people who inject drugs. And we have 4 esteemed panelists today that are ready to discuss their areas of expertise. Caleb Banta-Green, who many of you already may know, who is the principal research scientist at the UW Addictions, Drug, and Alcohol Institute, but also an associate professor at UW Public Health. Thea Oliphant-Wells, who is a social worker at Public Health Seattle-King County and has lived experience as well. And John Nusser, who is part of the Mountain West AETC HIV ECHO community. So many of you may already know him, who is a family medicine physician in Vancouver, Washington, who has developed some approaches for care delivery for people who inject drugs. And then Troy Seibert, who is the OUD Manager, so opioid use disorder manager for the Washington Recovery Helpline. So I'm very excited to have these 4 here today to discuss this very important topic. So let's just go ahead and get started. What I wanted to call on first is Caleb to just set the scene for kind of where we are in our area in terms of epidemiology and what we're seeing in drug use patterns. So Caleb.
Sure, I'm happy to do that. So as an epidemiologist, we really try to mix quantitative and qualitative methods, and I'll share a little bit of data with you. But some of the folks who I often turn to get a sense of what's going on are on this call. So that's exciting to have them here to tell you firsthand what they're hearing from folks. And I'm going to share one thing just to start with, because it really is the quite disturbing thing, and that is what's going on with overdose deaths. And people may well be familiar that overdose deaths are up dramatically in the United States, about 30% year over year to the most recent time point, depending how you count. And that is largely driven by illicitly manufactured fentanyl products, mostly actually fentanyl. And that's really quite striking, and people may well be aware of fentanyl. It's a pharmaceutical product that is widely used in hospitals and for very severe pain. But in this instance, fentanyl is generally getting tableted up in pills that look like M30s or oxycodone tablets. And I'll share with you that in talking with the medical examiner here in King County last year, every M30 they saw was fentanyl. In every case in which a person had oxycodone in their system at the time of death, they had a prescription. So they're really 2 completely distinct things at this point, where tablets off the street are virtually guaranteed to be fentanyl of completely unknown potency, right? Fentanyl is extremely potent, measured in micrograms instead of milligrams. And so the lethal dose, effective dose, is very close and makes it very, very dangerous. So, and I'm generally not very alarmist when it comes to drugs. I just don't find it to be very helpful, but I think fentanyl is really a very unfortunate game changer in terms of the potency and being a synthetic drug and illicitly manufactured. The profit motive is very high. Manufacturing and distribution is easy. And it may be one of those that is actually where supply is starting to drive demand, which we don't actually usually see when it comes to drugs. But in this instance, with something like fentanyl that has this sort of aura of safety and being a pill, even if people kind of subconsciously know better or consciously know better, it's quite striking. So I'm just going to share one data slide really quickly, and that is Washington State's preliminary death data. And let me just walk you through this. So this is these fentanyls. These data are preliminary and they're a little bit out of date, but you get the point here. We're going from something like 25, I'm getting my numbers, about 30 fentanyl involved overdose deaths in the first quarter of 2017, up to 115 and continuing. And this number is actually continuing up in terms of the fentanyls. We continue to see heroin. Heroin's pretty flat. Methamphetamine is slowly increasing, but very steadily. Over the last 6-8 years, is quite stunning what we're seeing with methamphetamine and drug overdose deaths. And cocaine is persisting, and we do see methadone always in combination with other substances. And then you see pharmaceutical opioids are also persisting as well, although down somewhat. So the big pieces of sort of what's going on in drug trends, and we'll talk more about it later when we talk about the syringe exchange data, really are the fentanyls and the methamphetamine. And what they have in common is they're both synthetic. They're both getting made and or processed in Mexico and part of that very efficient sort of distribution network. So those are the main things on the epidemiology side. You'll hear some other things from the other folks here, but I just want to make those couple of main points.
Yeah, thank you, Caleb. Troy, given your work at the recovery helpline, can you comment on what you're seeing in terms of trends?
Yeah, we're seeing some pretty, we were able just to kind of complete our data set for 2020, and we saw some pretty dramatic trends show up that kind of echo what Caleb just displayed there. In particular, calls on our line almost doubled in 2020 from 2019. Not completely shocking considering COVID, but still shocking when you look at just how dramatic that increase was. And then when you start kind of breaking down exactly, what folks were calling for in terms of like drug of choice, we've certainly seen a dramatic rise in fentanyl, as well as just kind of total opioid use. Looking at 2018, 2017 data, we rarely got a call that mentioned fentanyl. So that increased by, I want to say like 90% from 2019 to 2020. And we're seeing that continue in the early part of 2021 as well. So we're seeing folks who are actually now identifying fentanyl as their drug of choice, where before, it was even hard for folks to know if they were using fentanyl or not. So a lot of times that got underreported, and it still is, but just to see so many folks that are actually identifying that they are using fentanyl, they're maybe even seeking fentanyl is a pretty dramatic increase from previous years. We've also seen a pretty large rise in methamphetamine use. That is becoming kind of that next wave of concern as we're seeing those calls rise dramatically on our phone lines.
Yeah, thanks, Troy. Just a step back, can you just discuss a little bit of what your work is there or what the helpline does so people in the audience have an understanding of the work that's done there?
Sure. And my job is kind of twofold at this point right now. So I'm also helping to manage the Washington Recovery Helpline. So this is a 24-hour, 7-day-week service for those who are unaware. It's a phone line where folks can call in at any time and speak to a recovery specialist and get resources for a variety of treatment services. So this would be detox, inpatient, outpatient, to get an assessment, and certainly to get access to medications for opioid use disorder. And my primary role is managing our opioid use disorder program. So I have a team of 3 other people that we've been working to build and maintain what we call the MOUD Locator. This was something that my predecessor and Caleb actually kind of birthed this great idea to have a public-facing tool that folks can use to find out where they can get medications for opioid use disorder in their area in real time, as real time as we can get it. And you can hop on there, and I can share that too if you guys want to take a peek at that real quickly. Let me see if I can.
Thanks.
Can you guys see that?
Yes, we can.
Oh, okay. So that's kind of our bread and butter is this tool where you can go on. You can also filter for, what medication you're looking for, type of insurance you have, how quickly you'd like to get the medication, and a handful of other identifying criteria. So we manage that, the resources that are in there, making sure they're up to date and as accurate as possible.
Great, thank you for sharing.
Yeah.
So I wanted to call on Thea a little bit too here from a public health perspective, and then John in terms of what you're seeing. And I know that there was some syringe service program data that I would like you to share just in terms of trends as well from our area.
Wanted me to share the syringe service data?
Or Caleb, or yeah, whoever wants to share that. I know from your public health role, Thea, what are you seeing in terms of trends?
Very similar. I would say, the fentanyl M30 pills are our greatest concern currently with what's on the street, especially because they're being used by younger or lesser experienced drug users and not necessarily people who have a steady habit and a tolerance for opioids. So yeah, definitely fentanyl is an issue. Polysubstance use, always an issue. And of course, how people are living definitely affects their ability to manage their health and get the care that they need. And the homelessness crisis definitely feeds a lot of our other crises. So that's what I see.
Yeah, so touching upon some of the whys of what we're seeing in terms of this increase, you mentioned homelessness. Any other factors that any of you can chime in terms of why we're seeing these trends now?
Definitely people are isolated, because of pandemic and other, employment issues, all those kind of things that people have lost touch with. And people, need to have fulfilling things to do with their lives. And I know it was really difficult for a lot of people who were instantly cut off from their support systems, from their meaningful activities, and suddenly very isolated and alone. And we definitely don't want for people to be using drugs alone. That's one of our biggest risk factors. And so isolation is a huge issue for our community.
Yeah. Thank you. Any other thoughts, John, about in terms of trends of what you're seeing in your area?
Yeah, so I'm in Vancouver, Washington, right at the kind of southwest corner. And certainly, I think I agree with both Theo and Caleb. One of the things that we do, our faculty, Dr. Ray Wright, has started this, is manage the addiction end for and the prescribing for Daybreak, which is adolescents who come in throughout the entire state. And we've just seen a massive increase in fentanyl. It's really dramatic there. Yeah, I agree. I think the isolation in particular has been really hard. I think, as well as, when people have more structure and jobs, things like that, it's much easier to have other things that are fulfilling. And when a lot of that's taken away, I think some people just sort of fill that time, with, and turn to drugs as a source of comfort.
Yeah, thank you. So part of this, what we wanted to spend a lot of time talking about is really harm reduction in this population and approaches to treatment. So wanted to move on to that section and spend a lot of time talking about that, as everyone on this panel has a lot of expertise. First, we want to really bring up some harm reduction. The first sort of harm reduction measure is overdose prevention. Caleb, it brought up that we're just seeing an incredible increase in overdoses, particularly related to fentanyl, and kind of what we can do to decrease that. That's the immediate concern, is the deaths related to overdoses. So I wanted to ask the panel here some approaches regarding overdose prevention, and then we're going to segue into some other harm reduction measures as well. So maybe I'll start with John this time in terms of your approach for overdose prevention and some methods that you use, and then we can talk more general and from a public health standpoint, and then also the recovery hotline, what they're doing.
Yeah, I think it's an interesting question, and I think there's a lot of different solutions, and I think the clinician has a role to play in that, and I think an important one, and it's certainly not the the only one. When I think about, I mean, some of obviously education, I think, especially with my patients who purport to just use meth, I think talking to them about there's fentanyl everywhere, I think that's really important. And I think getting naloxone out as much as we can. And again, I think that there's a lot of roles for that, pharmacists, SUD places, but so certainly we try making sure that all our folks who use IV drugs, regardless what drug it is, have naloxone. All our folks who are taking opioids for chronic pain, we want to make sure they've got naloxone. Even our folks with on Suboxone or buprenorphine naloxone, we try to get naloxone as well, mostly just because they're more likely to run into folks who might use. So I think that's certainly, I think the education and the naloxone piece are kind of two pieces of that, but there's, I think, a lot more to that as well.
Great, thank you. Troy or Thea, do you want to comment a little bit also about overdose prevention and your work?
Yeah, I mean, I can second John there that, primarily when we're talking to callers that, we identify as IV using or opioid using, naloxone is we're talking about that in every single call. We really try to push that education piece, lots of referrals to stopoverdose.org to help people connect, make sure that they have Narcan on hand, whether that's a family member or friend calling on behalf of someone or the person struggling themselves. So the education piece is pretty heavy on our call with folks. Yeah, the good news is a lot of people are, at least that we're talking to, are saying they already have Narcan on hand, which is great, or they have some education about it. So that is not, or that's new. That's not something that we would typically see, a year ago or further out. So that's a little bit of a silver lining. But the best that we typically can do on the line is to educate about the dangers, specifically fentanyl, of course, and the fact that most folks aren't completely sure what they're using when they do use. So we try to push that, to at least look up resources on stopoverdose.org, and people have been very receptive to that.
Great, thank
Our
you.
biggest message currently is don't use alone. So naloxone is wonderful, but if you're alone, you can't give it to yourself. And we've had some folks pass away recently who had naloxone in their stuff, but they were by themselves. And so please don't use alone. Then yes, make sure you have naloxone. Make sure people know where your naloxone is. If you go out, you need to be able to have that help. And so naloxone is wonderful, but you've got to have somebody to give it to you. And so that's really an important message right now. And if you have to use alone, there's a couple of resources, the Never Use Alone line, which I'll put into the chat, which you can call and have someone, standing by in case you need help. Also, the Brave app is another one where you can enter your safety plan into the app, and if you fail to respond, they can retrieve your safety plan and follow whatever plan you've made. So those are two really good resources for that. And so yeah, definitely want to make sure that message is getting out there.
Thanks, yeah, that's really helpful.
I was just going to say, I think the challenge, a decade ago, and I'll show the stopoverdose.org webpage in a second, is, when you're looking at heroin overdoses, you're generally looking at minutes to hours, often hours. And with fentanyl, it's literally seconds to minutes. So that window is tiny. It's just tiny, which is the not using alone part's really huge. And I just share the two things on the webpage. This is our fentanyl page that goes over what is fentanyl, what does it look like. If you really want to hear an hour about fentanyl, there's my hour of fentanyl talk. What are the signs of fentanyl overdose? Same as any opioid overdose. How do you respond to it? There is also, it's important to know, there's misinformation going around primarily in the law enforcement community about unnecessary concerns about responding to a fentanyl overdose, that somehow touching a person or touching fentanyl is going to cause an overdose in a first responder. That is not correct. That has never been documented. It can't happen. So there's some information there about that if you're working with your community partners, how to reduce these risks, as Thea just described. The use of fentanyl test strips, which are really just a qualitative test that tells you whether fentanyl is present or not. They're a little tricky to use. They don't tell you how much is there. They're not perfect, but they are something. And they're also a nice engagement tool, because the other big issue here that we haven't talked about, even though we're primarily talking about injection, is almost half of people using heroin are smoking. It's probably higher than that for fentanyl. It's more than half for methamphetamine. So also being really mindful around the role of smoking it is important. So in fentanyl test strips can be an opportunity to engage people who may not be coming in for injecting equipment, but may be interested in understanding what's in their drugs. Here's some resources. This red flyer is from Public Health Seattle King County about some of those specific messages. And then quickly over here, Allison Newman at ADI just generated this flyer. Well, she's been working on it for a year with our syringe exchange partners, talking about methamphetamine overdose deaths. This data slide is specifically for Washington State. One thing that's really important to understand is that red area, that increase there, that's methamphetamine without other psychoactive drugs. Over half of those meth deaths are meth by itself, and that's new. That's a really new phenomenon. We usually think of drug overdoses as polydrug, multiple drugs. And in fact, that's what that pink section are those involved with opioids. So I just want to make sure people are aware of that. And the most important thing is most people use methamphetamine do not believe you can overdose on methamphetamine. So just the statement that you can overdose on methamphetamine, really, here's the numbers, here's some of the things you can do, is really important information. And this goes through some of those same overdose recognition and response data.
One of our providers just asked in the question and answer about resources for obtaining naloxone for free. Some patients aren't able to get it through their insurance, and so if you can chime in about resources.
So I'll say on the stopoverdose.org, the resource section is Washington State specific. I don't know where that provider's from. In Washington State, Medicaid pays for naloxone. Syringe exchanges give it away for free. There's even a program maybe Thea can speak to in King County specifically developed around young adults and fentanyl that will actually do mail order or pharmacy naloxone. I don't know if there's any more to say about that, but that's available at least in Washington State. And I believe Medicaid will pay for it in most states at this point.
And DOH actually also has a program for free naloxone distribution as well. Great.
I do see a question there, Shireesha, I think I'll just respond to really quickly,
Yeah.
which is about methamphetamine being contaminated with fentanyl. And the best we know right now, at least in the Northwest, that is extremely rare. There are some oddities about how those fentanyl test strips work that I think are giving some sort of false data. They're incredibly sensitive, those test kits, and people may often combine drugs in a goofball. Our sense right now is that fentanyl is primarily in pills. We've actually looked at also black tar heroin, and 94% of drugs that police seized that look like black tar heroin were black tar heroin. So right now, at least, all the signs are that fentanyl is really either in a white powder or in those pills. Absolutely, there are places where there can be kind of cross-contamination, there can be purposeful mixing, there are different patterns in different parts of the country, but right now we don't have a sense there's much fentanyl actually in the methamphetamine. To John's point, there's a lot of social network intermixing, and so there's no reason not to have naloxone right now if you are using methamphetamine, but the best that we know, we're not really seeing fentanyl in the methamphetamine.
The other question that came up is, where can someone get fentanyl test strips? Where can they get their drugs tested?
If you're in King County, we do have strips to distribute in King County, but as far as the state, People's Harm Reduction Alliance, I know occasionally has strips. I believe Next Distro may have some as well. I can put those links in there.
John and Troy, are you aware of any resources for John in your area or Troy statewide?
Our county has had them at the syringe exchange at times, but the supply has been variable. Honestly, even just in terms of checking in the hospital level, like I think the hospital labs really haven't quite caught up with checking for fentanyl regularly. I was just on a call yesterday around newborn care, and it's like, well, maybe we'll do the $600 test just so we can get the fentanyl thing. So it's been a challenge.
Thanks.
One thing on that I would say is to consider, is a fentanyl test strip is $1. And it's not perfect, but if used appropriately in a clinical setting, you're probably going to get a better result. And I do think it can be informative and helpful for clinicians to give useful information to their patients. And useful information might be, hey, did you know you're using fentanyl? So that's something to think about as a clinician.
Thank you. All right, so just on the harm reduction topic here, but switching gears a little bit from overdose prevention to tackling other diseases or infections associated with drug use like HIV and hepatitis C. So wanted to start with John here to just talk about kind of approaches to HIV prevention or HIV treatment and hep C treatment in people who inject drugs.
Yeah, so I think the one reference on this topic that's really useful, SAMHSA put out a prevention and treatment of HIV among people living with substance use and or mental health disorders last year, and that's got some really nice info on that. I think sort of there's a couple pieces to that. One is the, what to do with PrEP, and I think PrEP is really interesting because, we know it's this incredibly effective treatment when taken, regularly, up to upwards of 99%. Yet for folks who are using IV drugs, at least in Oregon anyway, only 5% of the PrEP prescriptions are for folks who are using IV. And so it's just like, how can we increase this amount? And why, and what are some of the barriers that are keeping us, keeping those numbers down? So I think part of the issue, I think, is sometimes it's challenging because the clinicians who have a lot of PrEP experience are usually in clinics. They're primary care, infectious disease, HIV. And so patients with active substance abuse aren't always coming into clinics for regular appointments. So I think one thing I think that we can do, as systems is really try to do more outreach to these folks. So, I think about things in King County, like the Max Clinic, like Shireesha, what you've done with the She Clinic, reaching out to sex workers. We have a project in Vancouver where we're going to folks who are living in permanent supportive housing, many of which have active addiction, and just doing home visits once a week. And so, you have a lot more conversations and a lot more contact. And I think that's really helpful. I think part of the issue for patients in particular is that a lot of these folks have had such horrendous experiences in the healthcare system. I mean, just the fear and, loathing and anger they have around that is really challenging because they've been treated so poorly. And so, reaching out to them, I think, is really helpful. I think the other thing too is, this is where peer navigators can play a huge role in bringing folks in, to providers, and providing patients some reassurance, like, this guy's going to be, or this woman's going to be okay. So, in terms of PrEP, I think, sometimes, when folks are seeing these patients who are using IV, they just, clinicians get distracted with, so many other things that they want to take care of. And so that doesn't always get to the top of the list, I think. So I think sometimes clinicians, we don't always do a great job at just truly connecting. We just end up pissing patients off because, we see them using meth and we get scared and we want them not to use, or, we want them to quit and they're just not at those places. So I think trying to make some sense of that, I think, is really, really helpful. I think too that there's a lot of stigma associated with PrEP, especially for people who use, especially men, who think that this is just for gay men. And of course it's not, but I think that's a message that, needs to be shared. This is really for anybody who has, who has issues there. And I think clinicians as well also fear creating HIV resistance. And so trying to make some sense around that. I think there's a lot of interesting solutions there. There's a interesting clinic called Faster Paths to Treatment in Boston. That is a low barrier clinic, SUD clinic. And they talked about, basically, when they were concerned, basically just starting people on PEP, even if it is after the 3 days, with the idea that you may not know that they've got HIV. And so doing that for a month and then starting the PrEP. So I think there's lots of ways of going about that. But it's challenging. And we can talk more about the Hep C business as well. But I think a lot of this is really just getting folks into care.
John, if I
Oh, yeah, go ahead,
I was
Caleb.
going to share two things. We did the Syringe Service Program survey was last done in Washington State in 2019. Just to let folks know, we did that at 24 syringe service programs with about 1,300 folks. And one thing we asked them was, have you needed treatment in the last year, medical care in the last year, and not gotten it? 60% said that was the case. And it's because of how they were cared for by providers, the stigma with which they faced. And rather than put this data slide up, I'll put the link in. I'll mention when it comes to hepatitis C testing, we asked folks, 60% had been tested in the last year, 40% had been diagnosed with Hep C, most had not been treated, but most wanted treatment. So again, one of these things that we often do with the syringe service program is document the obvious. But that's pretty important, right? Is that people generally are not treated very well in care, but they actually do want care, which speaks to what John's talking about, which is we need on-demand low barrier care. And hopefully we'll talk about that in a little bit because there's some really exciting work happening, on that front. I think about it like people are like, oh my God, you can give COVID vaccines at Dick's drive-ins with hamburgers. I'm like, yes. And the same thing, we're trying to make care easy for folks. And that's the same thing here when it comes to substance use disorder treatment, infectious disease treatment, and so on. As people having to navigate the labyrinth of our systems to get life-saving care is a little unkind.
Yeah.
Well, and I think it's important, as someone who's been an injection drug user and had to access a lot of broken healthcare systems, sometimes you just have to be willing to slow down with people and focus on the relationship. And sometimes, a provider has you need a pap smear, you need all the things, right? You haven't been in care in years, but if a provider tries to go to those things when that's not really what you're presenting for, you miss the opportunity. And so really slowing down and focusing on building a relationship with folks can really help that care, to be accessible down the road. And so any opportunity you can to really focus on what people are there for and not necessarily what you want them to be there for can go a long way. And I really believe that you can use tools like buprenorphine can be a gateway drug to primary care. It certainly was for me at one time. And so if you focus on what people's need is, you can start that relationship that then can lead to all of the other preventative care and regular, exams that you need and blood work and all of that stuff. But you really got to slow down sometimes with people and meet them where they're at.
Yeah, great point, Thea. I think, someone put in the question about Hep C, people may not be concerned about HIV or HIV prevention, but they are really concerned about Hep C. So using that and meeting them where they are and say, let's talk about the Hep C then, but we can also do those other things, like you mentioned, down the road as we establish that rapport and really listen to what their needs are and what their priorities are. Troy, you mentioned that on the MOUD locator that there's some other questions. Can people actually look for treatment with PrEP or Hep C treatment on that MOUD locator as well?
Currently, you can look for Hep C treatment. There was a great push to get these resources out to the public, a little over a year ago, pre-COVID. And so we did quite a bit of work to just kind of call around and see, and just working some of the contacts that we already have in the locator who are doing low barrier mound work. in particular to see, you know, who was offering Hep C treatment. So there's a filter for that. We also, we don't get a ton of calls on our phone line from people who are specifically identifying, you know, that as something that they need, but also kind of our calls are more centrally focused on, you know, quick access to, you know, detox, inpatient, MAUD. So the idea being, as Thea is saying, you know, MAUD being that gateway, that doesn't mean those conversations aren't happening once people are connected to services. But we have that in our internal referral database to go over with callers. And then we also have that on the Locator for people to search as well.
Great. I think that's a great segue to talk about MOUD then and approaches to MOUD. And I was going to start with Thea and to talk about shared decision-making and MOUD.
So once upon a time, Caleb and I met to talk about how to help people get into treatment, specifically getting on medication for opioid use disorder. And years ago, it was a very slow process that took a couple of months to get an appointment with a social worker. And if you passed that test, then you could get an appointment with a nurse. And if you passed that test, then you could get an appointment with a provider and you might get a prescription. And that, of course, was not the best way for people to access care. And most people didn't make it through all of those steps. And I was social working at the Needle Exchange and helping people walk through that process a lot. And really sitting down and finding out, what is it that you want? And sometimes people with OUD want detox. And I think that's fine if that's what you want. But we're also going to talk about some education around why detox can be not the best bet for folks. And also, if that's what someone really wants for themselves, I'm going to help them get that. I'm not going to say, no, that's not the right care for you, but I am going to make sure that people understand the overdose risk leaving, you know, abstinence-based care if they have OUD, and we're going to talk about that. I'm also going to talk about medications just in case they don't know, and let them know that that's their best chance of surviving, because really we want people to be alive. And so if we can lower their overdose risk by half, that's huge. And so buprenorphine and methadone, of course, are our gold standard. Methadone is very difficult to get into. And so oftentimes when people are seeking methadone care, we're going to talk about what that looks like. That's every day at a clinic dosing, which is great for building structure in your life and also can be really difficult to access for some folks. It's a very intensive kind of treatment. And talking about medications, I usually ask, do you use other drugs besides opioids? Because I know that some prescribers are not going to be okay with that. And I don't want to send somebody into a care situation that isn't going to be successful. So we're going to talk about what else is happening in your life and other things that you might be struggling with. Where are you living? What's your situation? And that way I can get a fuller picture of what people actually need and the best care system for them. Of course, you can't have a social worker on every corner. And so the MOUD Locator was like amazing, an amazing miracle for our community. And being able to just go online and do what I was doing, which took a lot to like maintain relationships with all of the referring clinics and making sure that our information was up to date. People oftentimes don't know what they want. They're just really uncomfortable and unhappy with the way things are. And so having someone that they can talk to about that, who isn't going to push them into something, but really who has some skill in listening for that change talk and pulling some of those strings and helping people, you know, along the path and leaving the door open. If this doesn't work for you, please come back and we'll try again. This is a chronic illness that you're going to be managing probably for a lifetime. And so understanding that setbacks happen, that recovery is not a linear process, all of those, buzzword jargony things, but those are true. People definitely need the opportunity to try and try again.
Great, thank you so much, Thea.
Yeah.
There have been some recent changes in ability to prescribe buprenorphine, and I was hoping that someone could comment on that and how it's now going to be a little bit easier for maybe patients to access, or maybe not. So people's thoughts about that, maybe Caleb or John.
Well, briefly said, for physicians, there was an 8-hour mandatory training before getting an X waiver from DEA, and that training is now gone. You still have to do your documentation, but that training mandate is no longer there. And I hope that will help some. Honestly, though, I have to say, I think the real barrier is stigma by providers, and also the constraints of healthcare systems and productivity ratings and fear of talking about difficult subjects. So I am hopeful that removing that waiver will help some, but we're seeing as we implement low barrier buprenorphine across the state, to Thea's point, I mean, it's very difficult to transfer clients to primary care because most people continue to use methamphetamine and or benzodiazepines some. And the point is that a person can still have an improved quality of life, be moving towards whatever their recovery looks like, even as they use those other substances. And there's also evidence that Dr. Judith Sui's done some work at Harborview that people who start on buprenorphine, yes, they're more likely to leave care if they use methamphetamine, but if they stay in care, the methamphetamine will eventually ameliorate. And that's one of the biggest issues. And I won't show the data at this moment, but 80% of heroin, people who use heroin right now use methamphetamine some or a lot. So to Troy's point, that's why that database is set up to talk about polysubstance use. Polysubstance use is the norm. That's normative. So the discussion about a person can stay on Suboxone and keep using methamphetamine and still do better. And that our goal is engagement and keeping that person in care. That is our, to me, that is our sole goal, is to keep that person engaged in care. And part of that is being kind, which Thea alluded to earlier, and non-judgmental, and offering supports. And, as we're trying to build more models, we certainly want to be offering low barrier behavioral healthcare access as well. That's generally needed for folks who have substance use disorder. And some of the most effective interventions we have in multiple fronts for stimulant use disorder are behavioral health interventions, including medications. Those medications focused right now because of FDA requirements on treating the comorbid psychiatric conditions, but might also indirectly help with that. So I just covered a lot, I realize that. But I think that shared decision-making process is super important. I just want to show really briefly on our webpage. I'll describe. Thea and I met over wheatgrass. She had wheatgrass, I had coffee. I want to clarify our different approaches to life. We worked on sort of building it out with people releasing from prison. And actually the state jail system liked that and tried our intervention out and found that it did have a significant impact. A half-hour shared decision-making process by reentry staff before release did double the chances of people entering treatment in the month after. So there definitely is, even with a very version 1.0 version, we saw some nice impacts. And then on the webpage, we have this webpage, learnaboutTreatment.org, which right now is opioid focused. We are in the middle of building up the stimulant side. We have a bunch here you can see around treatment options, which Thea talked about, medications for opioid use disorder, counseling, what is OUD, and treatment resources. I want to focus on the client engagement piece because that is sort of our code word for shared decision making. And this is a brochure. It's a 2-page brochure that is used with clients to go over the medications and the care settings. This is a synopsis of about a 70-page brochure that SAMHSA put out. So this is a 2-page version. And then we actually have a sort of an online provider's guide to using that brochure, sort of how to walk through that shared decision-making process. And again, the point is that there are options, there are pros and cons of each of them, and just trying to give some structure to that. So it might be that providers are more likely to prescribe buprenorphine if they have tools in hand to frame that conversation that they're very uncomfortable having. And I think that's super important. So we're just trying to give those tools to folks.
Yeah, and John, as a family practice physician who does primary care and does MOUD, and as an educator for our future physicians who are in residency. How do you approach that? Because I'm hearing Caleb and Thea really talk about meeting patients where they are and not necessarily having your goal imposed on them, which, that rigidity of, well, the goal is abstinence, which that may not be the goal for your client, your patient. And so how do you approach that in your education and your work with patients?
Yeah, it's a great question. And I think so much of this comes down to the idea of harm reduction, right, is meeting the patient where they're at. And I think that works for anything in medicine. And it's something as clinicians, we all need to keep working and doing better, because I think it's so easy to get caught up in, I want to do this and this and this. And that's not generally so helpful for what the patient wants at that moment. We train all our residents in prescribing buprenorphine. And I think, again, it's this other interesting paradox. It's like, even before the X waiver went away, there were, when I would go around throughout Oregon doing trainings, there were a lot of folks who are X waivered, but many of them not using, not prescribing bup. And I think some of it's just because they were, one, so nervous, what that would mean for their clinic, for them. Maybe they didn't feel they had all the skills for that. I think there are some great references for folks who are just starting to get into buprenorphine prescribing. And I think starting small and with easy patients, I certainly agree that, just because someone's using methamphetamine doesn't mean you should take the buprenorphine naloxone away. It's like, no, that's a terrible idea. Let's keep them engaged. And so the UCF warm line is a great source of support for providers, I think, and I think starting small, but, I think we just need to do this more and have folks get more comfortable. And I think it's going to require, a fair bit of handholding and sort of going around to practices to work with those folks. I think we just submitted for a SAMHSA addiction grant at PeaceHealth. And one of the things we were hoping to do, if we get it, is to, get folks started on all this and then work with the primary care folks at all these other locations where people might have some experience with bup, but not as much, and at least get them induced or get them stable or kind of help them along the way. And that's a slow process, similar to, I think, what we see with ECHO for HIV and Hep C. It takes time to build that capacity in primary care.
Yeah, thank you for sharing that. Troy, any other thoughts from your work at the Helpline?
Yeah, I mean, to kind of echo what John and Caleb have said, I think with any action, there's unintended consequences, even the best intended actions. And so, in working with providers, especially like those that we discover are newly into kind of the mild world and prescribing medications, it can be a little startling, the lack of knowledge about the complexities of opioid use and recovery in general. And so I've had a lot of, just what you've heard from Caleb's piece is more education than a lot of those folks are actually bringing to the table. And so, it can be a little off-putting when you hear the reasons why some folks are not prescribing and the reasons why they are, and just, opening up, this new law to so many people to be able to prescribe, it's going to be a mixed bag. If the motivations aren't, in the right place and the knowledge of how to support these folks isn't there, it's not necessarily going to be a beneficial thing. So, I've had some great conversations with providers to say, hey, here are some of the things that you need to be aware of, some of the things that you need to, think about before you start working with this population. the rigidity of well, I'm not going to work with polysubstance users. You know, abstinence has to be the goal. We're going to demand that they enroll in counseling, in therapy. And I'm like, well, you're not going to have a lot of clients. You know, it's the education piece, as John is saying too, you know, is huge. I think we're all still trying to figure out how do we get everyone on the same page, you know, and reduce the stigma, you know, reduce the amount of folks who are providing these medications without the proper knowledge of what else needs to be addressed, and how these folks need to be supported.
Yeah, I think, Caleb, you shared some resources for those providers. It sounds like if providers are interested, you know, knowing about some of these resources to reduce stigma in your clinic environment, in your practice. But then also maybe, do you have some other tools that people could look to? You know, I know that there's some trauma-informed care resources, just any other tools that you would suggest as experts in this area for providers who want to do this care and want to do it well?
A few things. I just did post a link around low-barrier buprenorphine, which did really come out of this work that Thea and I worked on starting in 2017. And part of that is the sort of the model of care, right, which is low barrier. Polysubstance use is allowed initially and ongoing, no counseling mandates. But the point that I sometimes forget to write down is be kind. And in fact, the feedback we get from clients who they keep coming back and they bring their friends in, right, is that you're the first. I with someone who said, I've been in and out of treatment my whole life. You're the first people who've ever treated me well. I've brought 6 of my friends into your program. And one of the things I actually remember hearing from Dr. Roger Rosenblatt before his passing that I really liked around buprenorphine is that buprenorphine, and working with a person with substance use disorder as a clinician, can change your relationship from being adversarial to collaborative. And I think that's one of the most important things. It can make your work easier. Treating a person well and giving them the resources they need is really important. So I did post there some of the information materials. I think that we have a video Dr. Mark Duncan and I did. We train on this low barrier buprenorphine model a lot. We are not unique in this. You know, people are doing this in Boston in a hospital settings. People are doing this in Missouri in traditional treatment settings. The part that's a little bit unique in Washington State is we're doing low barrier buprenorphine in community settings, at syringe service programs, at homeless service programs, where people already are and where they already have trusting relationships. That's really essential.
Great. People commented here. I just wanted to clarify one thing about the waiver, just for the audience, that it is still required if you're planning on prescribing for more than 30 people. And so this is really the doing away with that waiver piece, or the 8-hour training, is really to promote people in primary care settings to incorporate that into their practice. If your primary care setting is very enriched for people with OUD, then this is probably, you still want to do the training. I would suggest to make sure that you can offer a therapy to all your patients who want that. So again, this is just for people who are planning to prescribe to 30 or less. So thank you for making that point.
One thing I'll mention very briefly on that as well is that it's great to get people started on buprenorphine. And if you do it right, it's not that hard. The issue is, you know, keeping them engaged and also adapting the mindset that, oh, that person failed treatment, we're not going to do that again. We have a paper coming out probably this week, I think, looking at all the Washington State buprenorphine prescribing. And what we found is that for many people, it took 2, 3, or 4 episodes of care until they finally kind of clicked and they were engaged in care. And I think is the most important message is that both for clients and for providers is don't give up. You don't know when it's going to stick. And also within that, looking at not just a binary, are you on or you off, but recognizing buprenorphine as a harm reduction tool as well, that it represents about a 50% mortality reduction, easy. And that every day on care is an improvement for folks. And really this is a good example of sort of one day at a time. I think with buprenorphine, really recognizing it as both a public health intervention as well as a medical intervention.
Yeah, great. Thank you. Lots of great resources in the chat that we'll try to compile for the audience so that we can that you can continue to do that work. I want to open it up for any questions for the panel. What I'm hearing a lot is we really need people who are first and foremost kind and who are interested in doing that work, who are going to establish a relationship with these patients and meet them where they are in a stigmatizing, non-judgmental environment. I think those are kind of the key points that I'm hearing from this panel, that we actually have a lot of resources in our area if people are aware of those resources. And I think it just takes some time to get familiar. But Troy, thank you for bringing up the MOUD Locator and your work at the Helpline. That's really helpful for clients and providers so that they can know those resources. John, I know you're doing lots of great work in the Vancouver area with low barrier care yourself for these populations. And then Thea, as always, the champion there. And I thank you for sharing your thoughts about shared decision-making. And Caleb, for all your knowledge of the epidemiology in this area and all your continued work and research in this area. So I know that there's some questions in the chat. Some there were a couple of questions regarding fentanyl and someone asking that there was a temporary reclassification of fentanyl from Schedule 2 to Schedule 1. And so I think some people are just, and there was also another question about carfentanyl and kind of, I think, where is it coming from and how are people using it? Why is it still prescribed, kind of thing.
So just very briefly on both of those fronts, it's a noisy marketplace in a bad way. It is kind of settling in back on fentanyl. We saw carfentanyl, we saw sufentanil. So folks know these are even hyper potent fentanyl products, and which are pretty bad for business, as you might imagine. And so they actually went away pretty quickly. Right now, we're really looking at fentanyl as the main product that's out there. There still is no standardization in production. You still don't know how much you're getting, right? And if you don't know it's fentanyl and you don't have any opioid tolerance, you're really in trouble. So that's important around the fentanyl products. There are several out there, but it really is predominantly fentanyl. The other issue is around fentanyl's Schedule 2 DEA. There's a move to make sort of all fentanyl analogs Schedule 1, making them illegal, really with an emphasis. This is this consistent theme we've seen for many decades around higher penalties for fentanyl products. That sound familiar? And the issue is the people who bear the brunt of the majority of those higher penalties are the people who use drugs. And so while the instinct to protect people by making things harsher around certain drugs, like it's understandable at first blush, it really is extremely counterproductive in the long term in terms of thinking about the actual impact on people who use drugs.
And then there's one question too about how you address folks with fentanyl as a drug of choice. I think one thing in terms of coming back to the buprenorphine discussion is, if you are completely new to prescribing buprenorphine, the first patient you treat might not be trying to induce a patient who is on fentanyl, because that is a trickier situation. And there's techniques there like microdosing and things like that can be tried. But I think similar, to really with HIV care, with buprenorphine, I think starting with simple things, so you're not going to do HIV care overnight necessarily, but maybe you start doing PrEP for starters, and so same thing with buprenorphine. Maybe you start taking patients who have already been induced and you continue them and you get used to that and make some sense of that and realize, and you show your clinic and your MAs that the clinic didn't fall down, being besieged by, hordes. So, and then you kind of move into the more complex areas, which are induction and then, induction with fentanyl.
Great, thanks, John. It's really helpful.
I think that's like harm reduction for prescribers, just slow down, do a little at a time. Any positive change, we'll take it.
Great. There was actually an interesting question from one of our new Max providers here, just about are people researching whether days on Suboxone reduces the likelihood of illegal activity like theft, reduced chance of getting arrested. that data might persuade unsympathetic people in policy and law enforcement that harm reduction is good for society and not just the user. So Caleb, any work that your institute is doing regarding that?
Well, we're definitely looking at it, and there definitely are indications that it does so, and it certainly makes sense. It's just really hard when the criminal legal landscape is always shifting. And even in Washington state with change in possession laws, there still are goals around trying to prosecute people. If it's not for possession, it's for paraphernalia, and the things that become paraphernalia become pretty ludicrous. So we absolutely are looking at that in our work. We're definitely looking at in terms of outcomes as well. You always want to show cost outcomes, and certainly the cost analysis is very clear. Washington State Institute of Public Policy actually went to go do an analysis that was mandated of them around the role of injectable medications for treating substance use disorder, and found no cost benefit for injectable medications for opioids or alcohol, but did find substantial cost benefits for both methadone and buprenorphine. So cost is certainly a major issue as well, along with criminal legal system responses. I will mention quickly, we're actually doing a lot of work. Mandy Owens, who works with us with jails around Washington state, as they start ramping up, doing more treatment with medications while people are incarcerated. Obviously, we'd love to get people before they're incarcerated, but there also is a huge growth there, and there's a lot of funding in the state budget to improve access to medications while people are incarcerated and keep them medicated.
Thank you so much. And yes, I've asked Victor to put together the resources in the chat so that we can share them with the group, because I think all of you have put some excellent resources here for us providers or workers in this area to really inform ourselves and be better at the work that we do. So thank you so much for your time today in answering these questions. I am inspired by all of you, and will look at these resources myself to try to improve my work in with the people who use drugs in my practice. So thank you so much.
Thank you.
Thank you.